So I'm really pleased to introduce and moderate a little vignette that Dr. Alan Weiss and Tommy Centora, the patient, are going to present to you. And the reason why we're doing this is because we want you to be prepared when you go to your neurology appointment. And I'm sure you understand how important that is, but I want to point out that, and you probably know this, that medical appointments are really short, and you got to make really good, effective time while you're being in that examining room, and you really only have like 15 minutes tops. So you got to get stuff organized in advance, and it's really important that you sort of think through it before you get there. So I'm going to let Alan and Tommy do their dramatization. Then I'm going to ask you to comment on this and tell us where they've met your expectations and where they haven't. Okay?
Great to see you, Dr. Weiss. Thank you.
It's only been about a year and a half since we saw you last.
Yeah, I mean, about a year. I mean, things have been going fine, staying busy. Didn't really feel a need to see you, so I just kept canceling appointments, and now I'm here, I guess.
You're doing well then?
Yeah, I'm doing fine.
So I understand you've had difficulty in the past with double vision, eyelid drooping. How's that been going over the last year and a half since we saw you?
I can see real good out my good eye. That's good,
And last time I know you were here, you had a little bit of difficulty swallowing. How's that been doing since we saw you?
Swallowing's going fine. Yeah, yep.
No problem at all?
No problem at all.
Okay. And also, at times you were having slurred speech when we were here last time. How's that doing?
You can hear my speech is fine. It's good.
How is it in the evening?
It's perfect. Yep, speak well all day. My wife speaks a lot. If you can cure her speech... Oh, excuse me, Dr. Weiss. Oh, it's my wife. I got to take this. Hello? Oh, hey, babe. Yeah, I just made it to Dr. Weiss. I'm meeting with him. I got time to talk. He's good. He's got time. Yeah, I'm feeling fine. Did I take my list of questions for Dr. Weiss? Yeah, let's see. Okay, when will I be able to cut the grass, clean the litter box, do laundry? Yeah, I'll make sure I ask him that. Definitely. I'm not asking him that. Baby, I can't do that. All right, well, can I phrase it, have more energy, especially at night? I'm kind of shy about that. I mean, you might have to do all the work for a while. I'm just letting you know. All right. I'll ask him to prescribe something. All right. I gotta go, babe. All right. Love you too. All right. God. She makes me want to pop a prednisone. She really does. Oh my God. All right.
So how's your stamina and fatigue been? Because last time you were here, you were having difficulty.
Is this between me and you and not me, you, and my wife?
Yes.
Yeah, my stamina's great. Yeah, I have high energy levels. I'm doing good. Yep.
Mm-hmm.
Yep.
And the evenings you do fine as well? Or?
Evening, late at night, I do wonderful. Yep.
Okay.
Yep.
Now, you did bring your medication today.
I did. I have all my medication. Let me see here.
Dr. Bradley, let's see. You can bring one for me here. Let me see what you're on
here.
Yeah. So you're on Imuran. Looks like 150 milligrams a day. You're taking it every day as we
Correct.
tell you to?
Take it every day. Yep.
Okay. How about
So that's still the same thing. Sorry. All right. There you go. Prednisone.
And your prednisone. You're taking 10 milligrams a day.
Yep.
Do you ever miss a dose?
You want me to be honest?
Yeah.
Yeah.
Okay.
I kind of just take it as I feel. If I need to pop a prednisone, like I said, if the wife's nagging, I pop a prednisone.
Okay.
I put it in. If the boss wants me to do something, or I got to work late at night, yep, that's a good energy drug.
I think you're on Mestinon as well, I believe.
Right. So have you ever read the fine print on Mestinon? It says take one every 3 hours, shit every 5 hours. Have you ever read that? Isn't that awesome? So here's my anti-diarrhea medicine, so I kind of take that as a combination. But yeah. Now everything's going well. I just line up the pills. Sometimes I take them, sometimes I snort them. I'm good. I'm good. Good to go for the day.
So how much Mestinon are you taking?
About once every 3 hours. Yeah. In the bathroom. Yes. Yeah.
Are you are you taking it consistently every 3 hours or?
Like I said, as I need it, I take it. But yeah, it's about once every 3 hours. Yep, definitely. Okay. Eye starts to droop, I take it.
Okay. Now, Another thing I noticed, you're on Imuran,
Mm-hmm.
and we've not received any blood work in a while.
Yeah, I don't like that stuff. Yeah, that means there a need for me to do blood work every now and then?
You know it's important. Blood work,
I know.
side effects.
I know.
that
There's
can
a lot
be-
of stuff I should be doing. Yeah, you're right. Okay.
All righty.
I'll get back on it.
Okay. And the other thing, you had your thymectomy about 8 years ago.
Mm-hmm. Is that still in here? That
Is the what?
did you take it out?
Yeah, we took it out.
Oh,
You had-
okay,
you-
good.
you
Okay.
had a-
How am I doing?
You had a thymectomy.
Oh, right,
And we
right.
found a thymoma when we were there.
Okay, good.
So every so often we have to monitor your chest X-ray to make your CT of the chest to make sure
Okay.
it doesn't come back.
Gotcha.
You
Okay.
were supposed to do that about a year ago, I believe.
Yes, I missed that too.
You missed that too?
Yeah, you can
Okay.
add it to the list. I apologize.
Okay.
Yeah, it's tough. I mean, I'm gonna be honest with you. It's tough. Yeah, take all these pills.
Mhm.
Yeah, deal with
Now-
work, deal with the wife. Yeah, it's tough. Yeah.
Okay. Now I know you had some questions for me.
Yeah. Oh God, where do I start? All right, let's see. All right, so my buddy Mike took me out the other night. So we had a couple beers, 2 or 3. By the time it was 2 in the morning, woke up with this massive headache. That's got to be MG related, right? That's got to be. Am I right?
Probably not.
No. Okay. All right. So, okay. Here's another one. My wife, she talks. She talks a lot. Cannot understand a word she says. Have trouble listening. MG related? Is there another pill bottle I can take for that?
Yeah, I'm not sure there's anything for that as well.
Okay.
Sorry.
No. Okay. Yeah, that's all I got. I mean, that's my issues. I was just wondering if those are MG related. I try to just say it's because of my MG.
So, Tommy says the things we need to do. I mean, your myasthenia is not optimal. We know that right now.
Right.
I mean, you're having double vision. You're having your eyelids are drooping. You're having some fatigue and other symptoms. I mean, the first thing is you got to make sure you take your Mestinon consistently, not whenever you think it is.
Okay.
Because if we don't do that, then we don't know. You're hitting a moving target, so you really don't have a good idea what we can do to adjust things. And then with the Imuran, of course, again, we have to monitor that because we have to worry about your blood counts. You have to worry about liver failure and things like that, where, unfortunately, I've seen patients that don't do that, and you wind up having problems with it.
Yeah, I understand.
And then the other thing is you've had the thymoma. Even though it's been 8 years and you've done really well with the thymectomy, sometimes it comes back even when you might not really expect it to come back.
Right.
So
right.
we do want that monitoring every couple of years, at least once you get out a certain time.
Okay. Sounds good.
And then, so I want you to make sure you take your medications consistently. Don't skip the day of prednisone whenever you want to take it, or take an extra one.
Right.
And what I want you to do is in about a week, give us a call back.
Okay.
Okay. And we'll report on how you're doing. And then we'll make decisions if we need to make additional adjustments after that.
Okay. Sounds
Okay.
good. Yep. I can do that.
All righty.
Thank you, Dr. Watts. Appreciate your
You
time.
take care.
Okay.
All righty. In preparing for neurology, but the first thing is education. So everyone who's here, obviously you're gaining education with respect to the disease, which is critically important, because the more you know how to observe. I mean, in my mind, in looking at 20 plus years of taking care of patients with myasthenia, the patients who can feel that they can control their disease rather than letting their disease control them do better overall, by far. They don't get as overwhelmed. And understand, early on, it's very overwhelming. This new disease you've never heard of. But it's very important, to get yourself educated and to understand that we can control this to the best we can. So in terms of things, you need to know what your particular MG symptoms are. Not always, but very commonly when patients are doing well and they have difficulty, they may, ptosis may be their first symptom that is their first hint that they may be having their symptoms come back. Be aware of that. You don't need to perseverate on every symptom, but at least be aware of that. I think keeping a daily log, I think, is very important, because what we're looking for when you come into the office is looking for a pattern. If you can tell me, I have patients say, at 5 o'clock every day, that's when I do really great till 5 o'clock, and I then kind of peter out for the rest of the day. Well, we may be able to make medication adjustments, maybe increase the Mestinon or whatever, in order to basically help you through the rest of the day, where earlier in the day you don't necessarily need it. One of the keys is you need to have a list of all your medications. Now, with electronic medical records, it's becoming easier, but not only your list of medications, but know what you're taking and take the dose that you're supposed to take. Because when I have patients that occasionally will sit there and change their medications all over the place. Well, you have no idea. You kind of guess what you think is the best, that might be the right dose for them, and then slowly adjust it. But you can't hit a moving target is the problem. If we've made changes in your medications, how has it changed your myasthenia? For better or for worse? very important. The blood work, as Tommy didn't do, but I'm sure he does in real life, is you need to complete your monitoring blood work. It's inevitably the patient that doesn't do the blood work is the one that we find an abnormality when we do it. Basically, Amy and I like to get even patients who are on maintenance doses every 2 months, getting blood counts and liver function tests at the very least. Patients with thymoma, you should be getting CT of the chest basically for the rest of your life. Maybe every other year, but you should be getting it because it can come back long after you would expect a thymoma to come back. In terms of questions, prioritize yourself. Understand, especially if you're going to a neuromuscular subspecialist, that's what we're concentrating on. Doesn't mean we can't talk about your other diseases, but that's what we're concentrating on initially. So organize your questions in a manner that makes sense. One of the things you can do, and you should be doing this when you are having symptoms every day, to get a pattern, why am I still having the myasthenia symptoms? I have patients that call me between visits. Remember, we see you 15, 20 minutes every 2, 3, 4, 6 months, but your disease is all the time. So things you need to make sure, are you taking your medications as you're prescribed? That's very important. Number 2 is, have you started new medications? Because unfortunately, even pharmacists mess up once in a while and say, oh, no problem taking this with myasthenia gravis, and they in fact do have adverse effects for myasthenia patients. Are there any new medical problems? Do you have new thyroid disease? Well, that may impact your disease. Are there other things that are going on that may give us a hint as to why you may not be feeling well, may be unrelated to the myasthenia? Any recent infections or recent procedures, those can have an effect. The infection and also the antibiotics they give you could theoretically affect your myasthenia. Has your activity level changed? I have patients say, well, I'm no better than I was before. Meanwhile, instead of their level of activities, they can walk across the room, and now they're walking 2 miles a day. Understand is that's an improvement. It may not be exactly where we want to have you optimally, but it tells you that you're doing better. Or is your myasthenia affected by your activity level? You have a certain level of activity, you kind of do okay, and then for whatever reason, you're moving, you have a major event coming up, your activity level dramatically changes, it can also affect your myasthenia. Certainly being in Florida, not so much the latter, but basically exposure to extreme heat and humidity as well as cold. Very common. Especially in Florida, we had a horrible summer last year, started in the middle of April, ended the end of December. And we had lots of phone calls. But understanding what you do. I have patients early on, I'm going to go to the beach for 2 or 3 hours. Well, that's going to probably cost you a couple days in bed probably. It's just going to wipe you out. Another thing, have you made any adjustments of your myasthenia meds? You shouldn't be making adjustments on your own without letting us know. It's okay to let us say, gee, I think I need a change. You can talk about it on the phone, but you need to make sure that you're not making the changes on your own because that may lead to disaster. Because sometimes when you're thinking that you're not doing well, so you need to add more medication, you may be having a cholinergic crisis. You're on too much medicine, now you're just adding fuel to the fire. So other things, for the office visit itself, arrive early. Especially in the days of electronic medical record, there's a lot of information that needs to be inputted before you even get in to see the doctor, and the nurse is going to see you, or medical assistant's going to see you beforehand. So if you're late, understand that's going to back everybody up, and also that may be why you've been backed up. Avoid distractions, including the cell phone. If there's the rare instance where your child's sick, someone's watching the kid, at least say up front to your physician, look, I'm going to leave my cell phone on because I'm really worried about my child who's sick. But other than something like that, turn them off. Again, your questions you want to organize and prioritize. Don't tell me about toe pain and left hand numbness, which have nothing to do with myasthenia, and kind of leave the swallowing and speech things for last. And the other thing is make sure you're honest about your myasthenia symptoms. Patient, I'm doing great. And if we don't ask the next questions, we're going to say, okay, this person feels they're doing well. Because remember, we only see you for that short window. And especially if we're seeing you in the morning, you may be doing great in the morning and just doing horribly by the afternoon. So you have to let us know. Unfortunately, we're not psychics. And so if you're having difficulty, you got to let us know that. And again, don't minimize the symptoms that may be more significant, especially what I would consider some of the more life-threatening issues, swallowing and breathing are kind of important. So you want to make sure you let us know that. We also, a lot of patients with myasthenia have other neurological issues, and that's fine. But make sure we like to. I like to take care of the neuromuscular aspects first, take care of the myasthenia, and then we can address other issues after that. You do have to understand that not all symptoms that you think are myasthenia. Fatigue, for example, can be due to a whole host of reasons. Patients have difficulty breathing. Well, I have a number of patients who have myasthenia gravis and asthma. So you have to figure out, is it really your asthma or is it your myasthenia? Well, certainly if you're doing a lot of wheezing, the likelihood is probably your asthma, but sometimes it's hard to tell. One thing that's really important, I have patients that bring it to their other doctor's appointments, is have a list of medications that affect myasthenia adversely so they can look at that list. I also have, it's not uncommon, I get 2, 3, 4 questions, phone calls a week, is this okay to take this medication? It's okay to do that. Your physician has to be willing to answer the questions. Also, you're on a variety of medications. They all have, there's no medication that's out there that doesn't have risks and side effects. Understand what they are. If you're starting to have difficulty, we try and do the best we can to explain to you what the side effects and risks are. But if something comes up, and once in a while there's an unusual one that may actually be the case, but most of the time the common side effects are common. So make sure that you know what those are, and if there are issues, call us. Often with Mestinon, it's a matter of I think most patients, I just tell them to try and take it, eat first, then take their Mestinon. Seems to work pretty well. One of the things I know it's already been discussed is make sure you can understand myasthenic crisis versus cholinergic crisis. Are you on too much Mestinon or too little Mestinon? If you're on too little, that's easier to take care of, because once we give it to you, we can't just take it away. And probably more mistakes are made doing that when patient is on too much and it's not recognized. And the other thing is, use a daily log, the My MG app, to kind of log yourself. And there's this balance. You want to be aware of your symptoms, but you don't want to perseverate and make it your entire life. And it's a balancing act, and some of it depends upon how you're doing. So those are some of the things I think that are helpful.
Why does Mestinon help some patients and not others?
Well, there's no medication that we use for myasthenia that works in every patient. That's why we have a whole list of choices that we have, and hopefully with our researchers there'll be a longer list but some patients respond, some patients certainly what I've seen, especially the eyes, double vision and the eyelid drooping, may or may not get better with Mestinon. Sometimes it's probably, often you don't see that response, where with the immunosuppressants they seem to do a little better. Everybody's different. Even though we have a single name for the disease, this is a very heterogeneous disease. And you can line up 20 patients with myasthenia, they can have a whole different set of symptoms on a different variety of medications. Works great for patient 1 and doesn't work for patient 2.
I'm very new at this. I've only been diagnosed for a few months, and I have a general neurologist that I've seen a few times, but I'm aware of a couple of neuromuscular clinics within driving distance of me. And so I want to try to decide where I want to go to seek treatment. Do you have any advice for how I would shop, so to speak, for a clinic or a physician that specializes?
Certainly I think that for most patients, I think they're better off with a neuromuscular subspecialist who has a significant interest and expertise in myasthenia. The MGFA, what we do have on the website, I do believe we have the MSAB members. So the Medical Scientific Advisory Board members are on that list as a place to start. And that's from across the country in terms of looking where the expertise is. Doesn't mean it may not be all encompassing. There may be people that may not be on the list that maybe should be on our list, but at least it's a good place to start.
For somebody who didn't have a thymoma but did have an irregular thymus, should they get their chest CT'd every few years?
We don't generally recommend it all the time, but again, it depends. Some patients yes, and some no. I think some of it comes down to I think certainly if their myasthenia changes all of a sudden, that would be worrisome. Is that the case or not?
My chest has not been imaged since my thymectomy in 2008. Are you saying I should go and have it imaged?
You've had a thymoma?
No.
No. For thymoma, definitely, you absolutely need to. thymic hyperplasia, I think it's a little, I don't think every patient needs to have it continually monitored. One last question.
How many neuromuscular diseases are there?
How many? Dozens upon dozens, which is one of the reasons that in certain patients, especially those that don't have the double vision and the eyelid drooping, where it becomes difficult to make the diagnosis, is there are a number of patients who I've seen who came in with a different diagnosis and had myasthenia, and others who they thought had myasthenia had another neuromuscular diagnosis. So, there are a lot of them. That's part of the problem. And that's why, again, especially patients who are having any kind of difficulty with their myasthenia, I absolutely believe they ought to be in the hands of someone with expertise with myasthenia and neuromuscular diseases, because I think that, again, they have to, first thing you want to do is make sure that's the right diagnosis. And then, assuming that's the right diagnosis, then figure out what the optimal treatment is for that particular patient.
Just a qualification. Are you saying that if you had a thymectomy because you also had a thymoma, then you need repeat CAT scans to check on it?
Because it can come back long after the fact. And you may not always, some patients, who've done really well, their myasthenia symptoms may come back, which may give you the hint that it might be an issue. But some patients are completely asymptomatic and have the recurrence. And that's important from a treatment standpoint. That's much more serious. Would be considered a malignant thymoma and needs to be treated more aggressively.
How typical is it for a patient to go into remission?
In younger patients, especially in the pediatric population, it's fairly high. Some have quoted as high as 50%. I think in the adult population, it may be 15, 20%, plus or minus a little bit.
How important is it to, if you were tested initially for the acetylcholine receptor and you were seronegative, then how important is it to just continue testing to find out exactly what antibody you're dealing with?
We have only so many tests that are available. I think antibody negative may be worthwhile to get the MuSK. Other studies, as the newer studies become available, it's worthwhile. Occasionally there's a patient where we can't definitively prove it, but we want to do everything we can to have a confirmatory test that at least tells us that this is the right diagnosis. But sometimes it has to be, at the end of the day, it's still a clinical diagnosis. Testing is very helpful, but it's a clinical diagnosis is critical. Does it make sense?